Hello, everyone. My name is Chris Francois, and I was the program chair for the 2021 Scmr scientific sessions. And it is my pleasure to welcome all of you to our webinar today, where we're going to go over the best of Scmr 2021. We have an exciting program for the next hour or so. We have first up Dr. Michael Salerno, who is going to be giving us an overview of the highlights from the technical and scientific abstract program of Scmr 21. And then Dr. James Carr will be giving us an overview of the highlights from the adult clinical program from the meeting. And then Dr. Lars Gross-Wortman will be giving us some highlights from the pediatric and congenital heart disease clinical program from the meeting. And then I will be summarizing some of the highlights from the early career and professional development part of the program. And this should be about 25 or 30 minutes. And then we're going to open it up for a live question and answer discussion with all of you. And you can use the question and answer module that will appear at the bottom of the Zoom screen to enter your questions. And we hope that we'll have an opportunity to have a very lively and engaging discussion going over the highlights of the meeting and how that will impact the practice of CMR not only in the next year, but in the coming 5 to 10 years. And with that, I'd like to introduce our first speaker, Michael Salerno.
Hi, everybody. Mike Salerno. I'm going to talk about the technical sessions and some of the highlights from the meeting. So the first thing I want to talk about was the Ismrm Scmr workshop. Dan Kim and Suzanne did an excellent job putting this program together along with their program committee. And the focus of this was advanced CMR, cardiac mechanics, and hemodynamics. In the lead-off talk, Elliot McVeigh mentioned a couple of the points that I think really ring true for a lot of the other parts of this, is that the future, at least on the technical side, is free breathing, ECG gating free, continuous acquisition, and then thinking about things in automatic scanning and post-processing, leveraging AI. And that topic actually fits very well with this meeting where 4D flow and cardiac mechanics involve 4D flow, sometimes a long acquisition and challenging post-processing, and really places where these new techniques can really improve the clinical utility. And they talked about applications in vascular and valvular disease, myocardial disease, and AI and machine learning. Another highlight that I think it's also nice to go back and look at on all of the on-demand material is they had an open source demonstrations, and these included things including using synthetic grids to train CNNs, prototyping image reconstruction directly on the scanner using a framework called FIRE, the Glasgow Heart, which provides a virtual twin, and then SimVascular, which allows you to do CFD simulations. So one of the overall talks, which I would highlight as a good talk to get an overview of what was going on, is this talk by Pim, where he discussed different acquisition strategies as spiral Cartesian hybrids, Kushball, as really ways of speeding up the acquisition side, and then really thinking about deep learning and the fact that computational fluid dynamics, if we know the laws that they have to obey, we're able to basically train these networks off of the theoretical CFD. Brett Epstein gave a nice overview across different techniques, again, showing how we can use deep learning to do segmentation, unwrapping, as well as other processing. And this also extends across to feature tracking and other techniques as well, where we'll really see more utility for machine learning. So within the meeting, we had a core group that basically put together the talks in emerging methods across a couple of different topics. Just going to highlight the general ideas that came out. CMR in 2025, an interest in low field imaging. Rizwan Ahmed from Ohio State shows some nice work that they're doing. Obviously, very nice work also coming from the NIH on this. Free running, 5D, CMR, improved techniques for segmentation using deep learning, simultaneous multi-slice approaches to really speed up acquisition, and then really thinking about explainable machine learning and how we can really actually know what our algorithms are being sensitive to. Debbie Au gave a very nice talk that I recommend taking a look at, which is an overview of the different deep learning techniques. Right now, we're mostly in this supervised world, but there's some interest and growing interest in looking at unsupervised approaches. In the emerging CMR methods, one of the sessions was about motion correction and rapid imaging. The educational talks, two great talks, the talk by motion tracking was given by Pang-Hu and really showed a lot of where we've come over the last 10 to 15 years. And then really looking at how we're going to leverage deep learning for both acquisition as well as reconstruction. I think an interesting thought, at least that I took away from this, and it applies to our research as well, is that we can start thinking about, even in the absence of having a bunch of training data, how can we use different types of synthetic data to train our imaging. This was an interesting talk of using retrospective sampling from the Cartesian imaging to do radial training. In the section on tissue characterization, Anthony gave a great talk about multidimensional parametric imaging. I also would highly recommend taking a look at the other educational talk, how parametric mapping is used at my institution. I think this is really important to hear from a clinician about how this is integrated at their institution. A lot of really great points in that talk. Other things that were in this session in terms of the abstract, a technique from based on Sasha, work from Peter Kalman and Kelvin Chow, looking at bright blood and dark blood PSIR using this technique called Sasha. New techniques based on T1 row, where we may be able to look at scar non-invasively, and another technique called Saturn, which was using saturation and T1 recovery in order to do T1, T2, and T2 star mapping. In terms of the interventional CMR session, there were a number of interesting clinical talks on the technical sides, a couple of talks related to developing, improving the ability to do defibrillation in the magnet, as well as new guide wires. Some very interesting work at low field from the NIH group showing what native T1 contrast, being able to look at ablation lesions with very nice correlation to the ex vivo imaging. The last thing I want to highlight is that there were a number of really interesting talks in the early career award basic science session. Desire, some work from our group looking at deep learning based rapid spiral reconstruction. Something that I've highlighted here, this idea of self-supervised deep learning in order to do reconstruction for high resolution late gadolinium enhancement. Very interesting talk on having a way of measuring the electrical signals using a reusable clinical vest for clinical research and electrophysiology applications. And then a talk related to distortion correction. These were the more technical ones in the basic science section. So I think overall, my takeaway from the meeting on the technical aspects is that there's really a lot of interesting things going on in free breathing, self-gated data acquisition, this sort of idea of 5-dimensional acquisition, multitasking, how do we leverage motion correction, multidimensional parametric mapping, whether this is using low rank tensor, fingerprinting or other approaches. AI is essentially being used everywhere from designing the acquisition to doing the reconstruction, motion correction, post-processing, and really thinking about over the next few years, what's the potential for low field cardiac MRI? So those are some of my highlights from the meeting in terms of the technical side. And I really recommend people go onto the on-demand content, which is still available, to be able to take another look at some of these great talks.
All right, thank you, Michael. Next up, we have James Carr, who's going to be sharing with us the highlights from the adult clinical program from the meeting.
Okay. Thank you, Chris. Let me just share my slides. Hopefully you can see that right now. My name is James Carr. I am a radiologist at the Northwestern University here in Chicago and the immediate past president of the Scmr. So it's great to see everyone again. And I'm going to highlight some of the adult clinical material and discussions and abstracts that we saw at the meeting. I just want to point out that really all of the talks and discussions were outstanding. And obviously in this short session, we haven't got a lot of time to highlight everything, but really everything should be highlighted. So I've picked a few things which I think were aligned with some of the common themes of the meeting. And really, I think the very first one to highlight is really the opening plenary, which was a discussion on Cmr in patients with COVID-19. So this started with 2 plenary talks, finished with a debate and panel discussion. Dr. Blumke started off by giving us an overview of what we've learned from COVID-19 in the last year with respect to its impact on the heart. And I think one of the key take-home messages here was that even though there's been a number of Cmr studies that have shown involvement of the heart with COVID-19, that there have also been a number of autopsy studies which have shown that actually the prevalence of myocarditis is relatively uncommon. This is followed by a plenary talk by Dr. Raimondi, where she outlined the impact and effects of COVID-19 in children on the heart, and made the point that myocarditis is relatively uncommon in children, and when it does occur is more associated with respiratory illness. Then we had a debate between Dr. Eichenagel, who took the side of defending that Cmr is useful in all patients with COVID-19, and then followed that by Dr. Mariana Fontana, who took the opposing viewpoint, and then we finished up with a panel discussion. Just one slide from Dr. Blumke's talk, which summarized some of the studies outlining Cmr findings after COVID-19. These are just 3 studies represented. And you can see here that in summary, LGE was present in about a quarter of patients, and we saw a higher incidence of T1 and T abnormalities by Cmr in these studies to date. And then the session finished up with some take-home messages from Dr. Plein, where he summarized, as shown here, that myocardial involvement is relatively common after COVID-19 infection, and there are a number of different etiologies for this. Cmr is the preferred tool for monitoring long-term cardiovascular effects. Early studies have reported findings in diverse populations and using variable imaging protocols. The Scmr has actually provided some guidance on this, and I'll draw your attention to the website and the statement on this. And many patients may benefit from having a cardiac MRI, but I think the take-home message is that more data is needed, particularly when we look at prognostic information, and several large prospective outcome studies are currently underway, so stay tuned in this regard. As Michael alluded to on the technical side, we really had an outstanding early career award session for clinical abstracts, and they're all listed here. So obviously I can't really choose all of them within the constraints of time, but they were all deserving of being mentioned. The early career award for the clinical category was actually given to Dr. Jacob Lagan from Manchester University, who looked on the mechanisms and associations between COPD and heart failure as detected by CMR. And he found that ECV was independently associated with adverse myocardial outcomes or cardiac outcomes in patients with COPD, and was stronger than any other variable. An interesting sub-study that he also performed, and by the way, the first study was carried out in a large multi-center format with 572 patients, but he did a smaller sub-study using a USPIO agent and compared a smaller subgroups of normal patients, COPD patients and smokers, and found higher incidence of inflammation by CMR in COPD patients, both acute and stable COPD, as well as smokers compared to control. So very interesting findings from Dr. Lagan. We had a great debate on stress CMR versus invasive FFR between Dr. John Greenwood and Dr. Colin Berry, both interventionalists who also use imaging quite a lot. The conclusions here were really that FFR is very useful, certainly in the interventional environment. It is a well-validated technique. It's certainly very useful for invasive management during the procedure, particularly where you're treating a primary lesion. You want to decide whether you want to treat secondary lesions or not. It was also stated that FFR is very useful in microvascular dysfunction. However, both of our debaters, who debated in a very courteous and really engaging way, came to the conclusion that CMR is a really useful gatekeeper for getting patients into the cath lab, or more importantly, deciding which patients don't need to go to the cath lab. And both of them use CMR very widely. The question was put by Dr. Salerno whether CMR is ready to become the reference standard for evaluating ischemia in the heart. And the conclusion was really the evidence is out there right now, but particularly now with more of the quantitative data becoming available, that CMR may in fact become the reference investigation as we move forward, albeit we were discussing this in a somewhat slightly biased meeting, which is the SCMR. We had a great discussion on cardio-oncology. Again, a panel discussion. The talks had been provided by all the speakers prior to the meeting, and the attendees could look at these talks. It was very interactive. A number of conclusions listed here. CMR is obviously very good for looking at masses, both primary and secondary within the heart, but particularly when it came to cardiotoxicity, really CMR is useful, and there are a number of investigations out now looking at strain imaging, T1, ECV, all found to be helpful in identifying cardiotoxicity early. But all of the participants made the point that left ventricular ejection fraction is still the most widely used data point for suggesting cardiotoxicity. And the big benefit of MR is its more accurate quantification of left ventricular EF. Another point that was made by Dr. Hundley in this session is even though strain imaging is done by other modalities, the big advantage of CMR is ability to do an assessment of regional myocardial function as compared to other modalities, and particularly echocardiography. I wanted to highlight one abstract here just from the best clinical abstract session. This was by Dr. Wang from the University of Chicago. Again, on the general theme of the use of AI, she evaluated a number of different AI algorithms for calculating both left ventricular EF and right ventricular EF in a large number of patients, and found that there was a really outstanding and correlation between the manual quantification. And this also passed through when using both of the methods, manual and AI methods, for calculating EF as a predictor of outcomes. So again, just really follows the same theme that AI is with us and it will be a prominent feature for the future. And also on the abstract session, there were numerous clinical posters. I will draw your attention again, as Dr. Salerno mentioned, to go back into the online content and look at these. We had a machine learning tool presented which predicted mortality in pulmonary arterial hypertension. Again, cardiotoxicity from Dr. Harris at the University of Bristol looked at abnormalities of T1 and T2 and ECV in cardiotoxicity patients. And then we had a large study from the SPINS trial given by Dr. Antiochus from Brigham and Women's. So again, following these themes, in large patient studies used to evaluate various techniques, really, I think, compelling work presented. And again, I would encourage everyone to go and look at the posters. And then finally, I just want to highlight the symposia. These were industry-sponsored symposia sessions. One in particular that caught my mind because it was actually incredibly informative for CMR users. This was the one on the future of cardiovascular MR imaging summit, where we had a number of great speakers here, Dr. Friedrich, Dr. Cavalcante, Dr. Pennell, Dr. Plein, who really gave an overview of just numerous practical topics that we encounter when we're doing CMR on a daily basis. So the use of CMR in patients with implanted leads, lots of people are doing it. Post-operative temporary leads are considered safe. The role of perfusion, again, particularly the SPIN study was mentioned again, GATACAD, MR Inform. The conclusion here is that the data is out there to support perfusion imaging, but there are still obstacles mainly related to the protocol. So we need shorter protocols. That was the conclusion. Also, we need more training of physicians. And one interesting point that was brought up to really expand the reach of CMR as widely as possible, given the limitations of access to equipment and also training, was to really adopt a hub and spoke type model where you might even have larger centers which do reads for smaller peripheral sites within the community. So I'll just finish on that. I just want to congratulate everyone really on an outstanding meeting, great topics, great material. This has really been, I think, a huge contributor to the field, many outstanding clinical abstracts, and I'm really looking forward to discussion in this session and also next year's meeting. Thank you.
Thank you, James. And now I'd like to turn over the podium to Lars. You're up.
Thank you very much, Chris. So preparing for this highlight session here has really helped ease some of my withdrawal symptoms that I experience every time after SCMR is over. But it was obviously very difficult to pick from a huge array of really outstanding abstracts and invited lectures. And as my previous speakers have mentioned, I encourage you all to go to the on-demand sessions and look them up because we really have time for only a snapshot. The first invited lecture that I wanted to highlight was this presentation by Marcus Henningsen from Linköping in Sweden. He went over the need to keep our overall scan time in check. And obviously that can be done by being selective for your sequences, but he also gave a really nice overview of the techniques that are at our disposal, either traditional or up and coming, in order to shorten scan time, really spanning the arc from partial Fourier imaging and parallel imaging, compressed sensing reconstruction, which is becoming more mainstream, to other techniques where you can really combine different types of scanning approaches into one sequence. For example, sequences that allow you to grab the phase contrast flow information and also have really nice anatomical reconstructions in 3 dimensions. So that was a really nice talk in the state-of-the-art congenital cardiac MR session that I would really encourage you to go back to. What was interesting in the meeting is that the arena of congenital heart disease and pediatric heart disease, cardiac MRI, really spans the field from basic science, technical advances, translational research, and then mainstream clinical outcome study. And one of the technical papers was presented by Marcus Hott from Boston Children's Hospital, and he presented their data on cardiac self-gating used for free breathing phase contrast MRI. And this was really a proof of concept study What they did, they first of all measured the R-to-R interval by their self-gating approach and found that there was really good agreement with the ECG measured R-to-R interval and their self-gating measured R-to-R interval. And then they applied that to measure flow in the ascending aorta and also flow in the pulmonary artery, and found excellent agreement with the traditional phase contrast type of gating. So this really has huge potential in areas where you really either don't want to or cannot measure, obtain ECGs, for example, in fetal cardiac imaging. A study in the translational arena was presented by Joshua Chu from Vanderbilt University. He looked at how diastolic function were able to predict arrhythmia complications in repaired tetralogy of Fallot. So they measured these parameters that you can see here. So peak filling rate, time to peak filling, peak ejection rate, and time to peak ejection. And they did so in a cohort of 165 patients with repaired tetralogy of Fallot. And first of all, found differences in the peak ejection rate and other parameters as compared to controls. And they did find that there was discrimination between patients that had experienced an arrhythmia and those that hadn't in these diastolic function parameters measured with CMR imaging. So this really opens the arena into an area that CMR is traditionally at least considered not to be very good at because of temporal resolution constraints, which is the assessment of diastolic function. Ethan Johnson from Northwestern University reported on almost 600 patients who had a 4D flow MRI study. And they set out to answer the question, or at least get closer to answering the question, whether aortopathy that we observe in bicuspid aortic valve patients is more due to a structurally abnormal aortic wall, so a congenital or genetic component to the aortopathy, or is it all due to altered flow dynamics? And their huge patient cohort really allowed them to substratify their patients into tricuspid valves with aortic dilation and those with the bicuspid aortic valve and aortic dilation, but no AS, mild AS, or moderate to severe AS. And this, as well as spanning a huge age group, really allowed them to, at least in a simplified version, answer this question. They did not find that in patients with bicuspid aortic valves who did not have any stenosis, that there was any acceleration in pulse wave velocity as a marker of aortic wall stiffness and disease. But conversely, they did find that if there was altered flow dynamics, i.e. a obstructed aortic valve, there was altered aortic wall properties. This was perhaps my favorite session of the meeting. It was a session linking MRI to late complications and outcomes in a variety of congenital heart diseases, kicked off by Chris Lamb from Toronto, who really took the fear of lymphatic imaging away by dumbing it down and really walking us through how it's done and how each type of lymphatic imaging is used in the clinical arena. So I thought that was a really nice hands-on talk, followed by Tim Slethnik from Emory, who talked about congenital disease of the aorta, and in his typical, very stringent and organized way, walked us through the different types of lesions and how CMR is helping with outcome prediction in those lesions. Sonia Babanarayan from the Brompton, one of the world experts on tetralogy of Fallot, presented data on how different imaging markers, including late gadolinium enhancement and others, can predict outcome in tetralogy of Fallot patients after repair. And then finally, Rahul Rathod from Boston Children's talked about the various stages in the single ventricle journey and how CMR can help predict outcome and guide management in those patients. So this was really a snapshot of the congenital heart disease, pediatric heart disease content of SCMR this year. And please go back to the on-demand talks for a better overview of what was going on. Thank you.
Thank you, Lars. And so I'd like to briefly share with all of you some of the highlights from the early career and professional development sessions. And I'd like to just highlight a few of the sessions that were part of the early career and professional development track. The first session that I would like to highlight is the session on building a successful CMR program that included a presentation by Scott Flam from Cleveland. And he talked about some of the keys to building a successful academic CMR program, and really pointed out that it requires collaboration across disciplines, not only between groups that are going to be performing and interpreting the studies, but also reaching out and working closely with the referring clinicians. And also another key to the success of building an academic CMR program is getting involved in research, whether it's basic science research, translational research, or clinical research. And then there was also a really nice presentation by Ron Jacob from Lancaster, and who went over some of the keys based on his experience in building a successful CMR program within the context of a multimodality cardiac imaging program. And he really emphasized the need to develop rapid focus protocols that are designed to answer specific questions. Figuring out how to fit in a clinical cardiac MR study in a very busy general MRI practice. And then also, it's really important to simplify the process to order a cardiac MRI and simplify the interpretation of the cardiac MRI reports that are being generated. And then finally, we had a wonderful talk by Sophie Mavrogianni from Athens, Greece. And she gave a very nice overview of her personal experience in building a cardiac MR program in a very unique environment where she has been working for many, many years in Athens. And her key take-home points were the need to be persistent, not taking a no for an answer, being flexible, having strong self-discipline, being dedicated, strong support from friends and colleagues, and the courage to keep pushing forward to become successful. She also emphasized the need to have not only a strong knowledge of how to do cardiac MR, how to interpret the images, but you really need to have a strong clinical background in cardiac MR to kind of put everything into context. The other session that another session I'd really like to bring all of your attention to is the session on CMR from around the world. Started with a wonderful talk by Katia Manacho from Lima, Peru. And she really pointed out how it is possible to make CMR happen everywhere. Went over some of the barriers to cardiac MR access, that some of these are unique to places where cardiac MR is really just starting to be introduced. But I think if you kind of go back to the previous session, a lot of the barriers that need to be overcome to improving access around the world are really common everywhere. She also pointed out the need to have focused cardiac MR protocols, targeting applications where there is proven benefit. And I think if you go back to some of the talks and the sessions that have been highlighted by Michael, James, and Lars, I think we're really entering a time where cardiac MR more and more is being proven to be beneficial in improving, not only diagnoses, but at predicting outcomes. And so it's in those areas that we really need to target the growth of cardiac MR around the world. And she had this slide. This is a paper that was highlighted a few times within the early career and professional development sessions, the experience from the INCA study, where they highlighted how it's possible to go from an average of a 1 hour study that might cost $800 down to an 18-minute study at $150 per study. And by really focusing on the essential sequences, and not only that, they showed the clinical impact of introducing this rapid cardiac MR protocol focused on the diagnosis, how it really had an impact on patient care. We made new diagnoses. And then Dr. Lilia Ciar Galan from Mexico City in Mexico highlighted or went over how to set up reimbursement for cardiac MR, emphasizing that every country is unique. And it's really important to focus on value-based care, really emphasizing that cardiac MR provides excellent value when you compare it to other modalities. And then Sebastian Kell from Berlin, Germany, gave a very nice talk showing how companies and industry can help set up cardiac MR services in areas where cardiac MR access is difficult, whether it's companies that can help set up the reimbursement from the very beginning, but also they can help ensure state-of-the-art care is available everywhere. And then Dr. Marco Franconi from Rome, Italy, gave us a nice overview of how COVID-19 is impacting the practice of cardiac MR around the world. And then the final session that I'd wanted to highlight for all of you is the session on Cmr utilization and reimbursement. We had a very nice talk from Dr. Craig Hamilton, Dr. Christian Hamilton Craig from St. Lucia in Australia, who gave his perspective in Cmr utilization and reimbursement, particularly focusing on Australia. And he pointed out how cost modeling has been important in his practice in, again, further demonstrating the cost of effectiveness of cardiac MR relative to other modalities as a mechanism of growing the practice, where in Australia, Dr. Ted Martin from Tulsa in the US went over Cmr utilization compared to other cardiac imaging modalities, and said that, really pointed out that although cardiac MR use is increasing, steady growth of about 8 to 10% per year, its use is still dwarfed by other cardiac imaging modalities. And some of his points were perhaps unique to the environment here in the United States, but I think there are important lessons that can be translated to other regions around the world as well. And then finally, Dr. Michael Adelaide from Providence, Rhode Island in the US, went over, gave a very nice perspective of how cardiac MR utilization compares to other MRI studies. Again, one barrier that we face is that cardiac MR traditionally is allocated a much longer scan time, which creates barriers to access to this technology. Despite that barrier, he went back the 10-year period from 2008 to 2018 and found that, again, there was a steady 8% increase every year in cardiac MR studies. And what was interesting is that, over that 10-year period, almost all of the growth was for cardiac MR morphology and function studies, sort of highlighting, like there's an important opportunity if we go back to some of the talks that were highlighted by James and Michael to increase the growth in some of these other areas, some of these where CMR is really demonstrating an important advantage relative to some of the other modalities. So some take-home conclusions from these sessions: CMR is growing worldwide, and the keys to continued growth, I think, are to concentrate on focused, rapid CMR protocols that can be implemented into very busy general MRI practices, or if it's a dedicated CMR practice, to improve access, to increase access, again, by concentrating on these focused, rapid CMR protocols, it's going to facilitate that even further. Collaboration with colleagues in other areas of medicine, in your administration, your research colleagues, and industry are going to ensure the future success and growth of your program. And again, just like to emphasize that CMR really is cost effective. It's really going to have an impact on the well-being of our patients. And with that, again, I'd like to remind everyone that all of these sessions are available on demand. If you go to the on-demand tab of the virtual2021.scmr.org website, these are going to be available for another 2 months. And then I'd like to remind everyone that this webinar is being recorded and will be available I think within 24 hours after the webinar. So if you want to go back and review some of the sessions that we've highlighted as well, you'll have that opportunity. And with that, I'd like to thank all of you for your attention. We're now going to open it up for a live question and answer discussion. Please enter your questions in the chat tab. And with that, I think we'll turn it over to everyone at this point.
Thank you, Chris. While people are thinking about questions, I would like to pose a question to you as well as to James and Michael. You highlighted the need, to collaborate, and one of those collaborations can and should be with industry. What tip and advice would you give to somebody who does not currently have a strong collaboration with industry? How to forge that and how to facilitate that. What would you tell people?
Well, I think there are 2 questions, right? So one is a question related to how do you do that on the research side, and also how do you do it on the clinical side? I think on the clinical side, one thought is that we have a lot of techniques that people have developed over the last, and actually Elliot made this point really nicely, right? How do we communicate with our industry partners to really let them know that we need all these new advanced things that make things more efficient, packaged in a way that they're very useful. So I think some part of this is really going to be talking with our, industry partners to really let them know what things are really important for us in terms of practice. I think on the research side, certainly being at a place that has a set research relationship makes it a lot easier to sort of crack into having a research relationship. But I think, again, being at the meetings, reaching out to the industry sponsors and let them know that you're interested in being involved in research and other things is probably a way to get that started.
Maybe I'll try and echo that then with the clinical dimension. It is different, I think, as you alluded to, and from an industry perspective, they always will want to keep research separate to clinical. So you have to look at it from two different perspectives. I think the simplest way is finding your local application specialist. That's probably the biggest benefit. And there is going to be an application specialist assigned to your hospital, depending on who your vendor is. And I would, make an appointment, have them sit down, block the scanner for several sessions and sit down with that application specialist. And first of all, have them clean up your menu of protocols. That would be the first step. And I would almost subdivide it into basic and other, and use your basic protocol for nearly everything, particularly if you're getting started, and get your technologists that are doing cardiac MR to really get familiar with that basic protocol. I would also encourage the application specialists that they also try to integrate as much of the automated setup procedures that are now available as much as possible into those protocols, because they can be very advantageous, I feel. And some of this was presented at the meeting, but really it's hard to, first of all, know how to use them. And I think the application specialist can inform the local staff about how to use that. The other thing is, I would encourage the vendors maybe that these automated setup techniques should just come with the protocols. They shouldn't be, add-ons. It shouldn't be extra licenses. It needs to really be part of almost the basic package. And if that occurs, people will use them.
Thank you.
I think we have a question from the audience that sort of parallels one of the questions I wanted to ask all of you with regards to a 15-minute cardiac MR. And so I guess one question is, how close are we to a comprehensive 15-minute cardiac MR exam? And is it going to be as useful as an echo? And I think we can look at it on the adult side, but I'd also be interested to know Lars's thoughts on his perspective with regards to congenital heart disease.
Well, maybe just for clinical real quickly, I think we're there. There's a lot published in this area. As you showed in your few slides, Chris, about how this is being done in South America. There are publications that have come out of the UK, out of the US, both for the basic protocol and perfusion imaging, that you can do it in 15 to 20 minutes. So I think we're there. It's a basic protocol. But the meeting is full of all the advanced techniques, and that's great. And it really instills excitement, and it shows where the field is going and what the future looks like. But right now, you can use that very quick protocol, a very quick 15-minute protocol, just using the basic techniques that we've had for many years. So that's my opinion on the clinical side.
Yeah, I think a couple of things from the kind of the adult echo. First of all, I think it's important to note that at this point, at least in the US, the Medicare reimbursement for an echo is not that different from the Medicare reimbursement from an MR. So the real issue then becomes that we can say things are cost effective, but it's also thinking about how much time things are spending on the scanner. So the less time you spend on the scanner, the more other things you could be doing on the scanner as well. In terms of the information content, in terms of the LV function, we could do this very quickly. You can't get the tissue characterization from echo that you get from MR. So if we, is brought up in the talk from Lima, if you focus on what are the really key things, we can do this, we can do this quickly. And taking that one step further, the same thing with stress. We can have much more efficient ways of dealing with our stress protocols. I think the couple of advantages of echo in terms of the utility is that you can do it at the bedside, and probably still, at least for looking at stenotic valvular lesions, it probably has an advantage over MR.
Yeah, so for pediatric patients, obviously the other motivator to cut the scan time short is if you have a child who's not going to tolerate a lengthy Cmr exam. I just had a fairly young child yesterday who I knew could be jumping off the table anytime. In fact, he was doing jumping jacks while we're trying to position him on the table. That was the first for me. But what we did is we prioritized what I wanted to get from the MR, which was, asking ourselves what's relevant for clinical management and what's added value over an echo. Everybody's going to get an echo, at least in congenital heart disease. So do you really need to do a full short axis stack for ventricular function if echo tells you it's a normal, the ventricles seem to be normal sized? So I would encourage you to focus on the things that MRI adds in value. There's many things that we can do to accelerate the scan time by just being smart about the scan, not letting your scanner be silent. So, avoid having sequences one after the other where you need the previous sequence to plan the next one. So put something in between. Never have the scanner on silent. That'll get you, a good deal along the path of, shortening scan time. And then there's obviously the whole arena of image acceleration. And again, I encourage you to go to Marcus Henningsen's talk for an overview. We may, and this may not be very far away, get to a situation where we do one or two sequences that are 3D, 4D, or even 5D sequences, typically enhanced by ferumoxytol or other contrast agents that just boost up the signal. Hopefully, we can have a 10-minute acquisition with one of those sequences and have the anatomical, the flow, and the functional information all included. Right now, that's not mainstream, but I think that's the future.
Maybe I have a question for Michael. You highlighted some of the continuous acquisition, self-gating, both ECG and respiratory gating protocols or techniques that were presented. I've always found them really intriguing because when we talk about simplicity and, easy to run and push button, that's kind of the approach. And even what Lars was talking about, I'm assuming this would have great benefits in congenital heart disease. How close do you think we are for all of us to get access to this at the scanner? Are these close to becoming clinically available and applicable potentially?
Yeah, I think some of the work is a really good question, and I think there's sort of two different things that we have to think about in terms of approach. So one way is in the 2D approach, the approach may be that you do a lot of things real time and you just do them fast and you get things done that way. When you start thinking about doing things in 3D, you're really limited in how much data you can really acquire in just a real-time fashion. So you really get into this regime where self-gating and respiratory correction become important. And then once you start getting into that field, you say, well, you get an economy of scale if you're doing this in 3D and you're actually encoding multiple different dimensions at the same time. So I think I also agree that it's intriguing. I would think it's probably a small couple of years off. I would hope that probably in the next 4 to 5 years, some of these things are available clinically. I think some of these things should be available from the vendors in sort of a works in progress type approach within an even shorter period of time. And I think that the real question that we'll have to see over time is how robust are all these techniques when you apply them clinically and on real patients. And so I think there's a lot of potential. My gut feeling is a small few number of years off. I don't know what you guys think from the congenital or other perspectives.
No, I think that that's 4 or 5 years. I think is they pass quickly. That may still be an ambitious time frame for mainstream, but the technology is out there. I do want to highlight though is one thing. Those techniques I predict are going to work for 80-90% of your patients, but you're still going to have the flexibility and be nimble to pivot and shift your approach to a more manual, more tiered scan protocol, even when those techniques become available, because there will be situations where they just don't work.
Yeah, one other thing I was thinking, Lars, related to that is, in your opinion, do you think in terms of getting the things we need to see, particularly in the congenital case, what's your thought over sort of real-time 2D, steer things, planes automatically versus doing all these things with 3D and getting volumes? It seems like, pediatrics might be a little bit bigger than adult, where, a little bit things can be connected in much more complicated ways and other things. So what's your gut feeling about which way that goes in the future?
Yeah, that's one of the key questions, actually, Michael. Essentially, if you have it all in one volume and have all the information contained, then you can do your slice prescription on the post-processing console. That's the approach. And my hope is that it will work. There's obviously still a lot of manual interference here needed, because if you take phase contrast flow velocity mapping, for example, you're dealing with vessels of vastly different target flow velocities. Yeah. And so, is the same acquisition really going to work for a venous profile versus and at the same time for a stenotic artery? So this is where, you might find you need to do some more manual adjustment, and do you really detect it in time for you to grab that additional sequence? So that's one concern. But overall, if we had it all in one data set and it was reliable, then that would be great. I am one of the proponents that a physician needs to be at the scanner for a complex congenital heart disease scan, and I have a hard time seeing that go away, because there's just that value of having control and being anticipatory about what you're getting with your scan.
Well, I think we're coming up on the hour here for the webinar. I think I'd like to thank the panelists for sharing their thoughts on the highlights from the Scmr 2021 meeting. I would like to thank everyone that is here in attendance. And as just a final reminder, this webinar has been recorded and will become available on the Scmr website, as well as on the virtual2021.scmr.org website. Please go back and see all of review the sessions that you missed. Go check out the posters. And with that, enjoy the rest of your day and have a great weekend, everyone.